I love that Donna and I get to have conversations with such a wide variety of individuals about substance use. In this episode, we ask the president of the Canadian Society of Addiction Medicine, Dr. David Martell, to share his insights with us around harm reduction, recovery-oriented systems of care, and a pile of other highly polarized topics around drug policy in Canada. But before we get into it, what's up? My name's Dan, podcaster, keynote speaker, and advocate, and I'm joined in studio by my wife Donna, who is also all of those things, and this is Hard Knocks Talks, your addictions podcast. Now, let's get into our talk with Doctor of Addiction Medicine, David Martell.
This is Hard Knocks Talks.
Hey David, how are you?
Hey Danny. You go by Danny? I called you Daniel the first few times I met you.
You can call me Daniel. You can call me Danny, as long as I know who you're talking to. People ask me that all the time. Do you want to be Dan or Daniel or Danny? And I'm like, I don't care. Whatever rolls off your tongue, as long as I know who you're talking about. I'm interested to know why addiction medicine. Did you have a specific experience that sort of steered you in that direction, or like tell us more about why? What's your why?
I took a job here in a small community in Nova Scotia. I'm from Nova Scotia originally, but when I moved back home, the job I ended up diving into, which was as a family physician in a small town, Lunenburg, where I still live. The community has a small hospital, and that hospital had a withdrawal management unit, a detox unit, and I used to have to walk through it each day that I had a shift working in the community hospital emergency department. And just walking through it, I came to interact with the people who worked there and the patients who were there. And I found that they were, somewhat unsupported. They hadn't had a physician as part of their team for about 8 years when I arrived on the scene. And many of the patients who were there did require some medical attention. And where they were brought was kind of to the on-call ER physician. So it ended up being me anyway. So I offered to help out. Said, maybe you're going to have to get some help for these people anyway. Why don't I help you here instead of bringing them over to the other side? So, and that kind of, little by little led me to take more and more of an interest in and see the rewards of helping people with substance use problems. I discovered that the work isn't incredibly complicated. It's straightforward. It's not as daunting as it seems to someone who doesn't have training in addiction.
When you first started walking through this space and seeing these people struggling, was there ever any place where you were like judgment, like why don't they just quit, or kind of what's wrong with these people, or perhaps, as it goes in society today, we often get judged on the behavior we display. Was there any of that stigma in you when you first started coming into contact with these people?
I'd say yes. In full disclosure, I look back to the very early parts of my career, where, having had no experience, no personal experience, no family experience, no clinical experience with substance use or substance use disorders, I didn't know, at that point, I don't think I really even had an appreciation that these were medical problems. And I think that some of that attitude still exists in large swaths of society. And I remember thinking way back then, an occasional patient would come in and would say, oh, I really need help getting off of drugs. I'm horribly sick. I can't get any today. And thinking in my head, why is this my job? Why should I help you? You did this to yourself. And just completely stigmatizing attitude. And it took me, I think, getting to know on a more human level what was happening and what the support was needed. And more importantly, that there was treatment, there was hope. And this is actually, a neuroscience informed medical issue, no different than any other kinds of mental illness. So I think it starts with understanding, it starts with training, but it requires a change in thinking and a change in attitude to get rid of some of that judgment.
Yeah. Can you tell us about maybe some of the experiences that you had in those early days that started to shift your thinking?
Some of them might even seem silly. I mentioned about having to walk through this withdrawal management unit or detox unit. And I remember thinking to myself, I really don't know anything. Like I've never been taught anything about what medicines, what tests, how to interpret a drug test. I don't know anything at all, but I'll sit and chat with you and see what it is that you want
Mm-hmm.
or need, or what the problem is. And time after time, it ended up being something really silly, like, you know what, I've got asthma, and I'm out of my inhaler. It's like, what? That's it? That's not even a, that's not even a anything to do with addiction.
You're
It's like,
not
oh
here
yeah,
to
no,
get
but I've been to the
drugs.
hospital. Yeah, I've been to the hospital 3 times, and they won't see me and talk to me about my breathing,
Uh,
because I have these problems with alcohol or drugs. And
yeah.
I thought, boy, this is kind of strange. All I'm really doing is family medicine things. This is routine stuff, and that's what helps you. It kind of caught me off guard, but it was the simplicity of some of those requests or requirements that got to me. It wasn't complex,
Now, in helping these people, now surely they would, like, some of these people would come back and see you for different reasons. I'm wondering if you started to realize that the power of relationship, the power of compassion, perhaps moved some of your patients further along on a pathway to wellness than they would have otherwise found with someone else.
Yeah, that I think to me that's still the part that's reinforcing. That if you
Mm-hmm.
just try to connect with someone, anyone, in a mental health setting, in an addiction setting, at a human level, and spend the time talking with them and listening with them, that itself has value, and that is what leads them to want to set goals and want to stabilize their life, and go, they think, boy, this person I'm speaking to sees worth in me. Maybe I should see some worth in myself. And I think that connection really has a lot of value. I think it's
Mm-hmm.
one of the most therapeutic things that we can do.
I mean, I would, and Donna can speak to that, 100%.
Absolutely.
Would you like to?
Well, because I had such a range in years, very early on, my interactions with the healthcare system were incredibly negative. But towards the end, it was better. But certainly, my path into recovery was by accessing community-based organizations.
Mm-hmm.
Yeah. I mean,
And
accessing anything generally through the healthcare system was very challenging. Too much paperwork, a lot of wait lists. Fortunately, I think one of about the only healthcare-based systems that I interacted with was Healthy Mom, Healthy Baby.
mm-hmm.
But I was deemed a woman in crisis because I was fleeing domestic violence and I was pregnant. And so, they prioritized me.
Sure.
Yeah.
Mhm.
So as we're moving, the conversation is moving more and more forward in Canada and beyond. But and it seems like everybody was like, yes, harm reduction, let's do safe supply and supervised access or supervised consumption and clean supplies and all of these things. And it seemed to really be gaining traction. And in fact, there are several organizations that are now government funded that are run by people who are using substances, that got pretty loud, and they are still loud. Now, but in recent years, like even in the past year, we're seeing, okay, now there's a push back. Now people are like, oh, recovery oriented systems of care, and we're going to take everyone's clean pipes away, and hoping that because we were sending them the wrong message that it's okay to use drugs. And it's just a firefight, like just when you think the pendulum is slowing down and we're going to find a place that we can all get along, someone comes along and kicks it and it starts swinging again. So I'm interested to know where you're at with that in the conversation that's been going in the past 5 years. Like when they started really making a lot of noise about harm reduction, making a lot of noise about safe consumption and a regulated supply and all of these things, where did you stand on that? Were you like happy to hear about these things, or did you have concern?
I think part of me was certainly happy that the conversations were coming up. Anytime people have passion and have words and get all fired up, to me that leads to something.
Mm-hmm.
Complacency and silence is something altogether different, where we're never really going to build much of anything if people don't have an interest in pursuing stuff. So
Mm-hmm.
just the fact that we're having debates and disagreements and conversations can harness that energy, but I think it helps propel us forward. I'm often in settings where that comes up. This is a group of people who don't know a lot about addiction, and they'd like you to speak about harm reduction. And some people even, I think, envision harm reduction or use the words harm reduction as like a noun, like give them the harm reduction, as though it's something that you put in a box, and
Yeah.
they have absolutely no idea.
Yeah.
So kind of changing the tone of
Here
those
comes the harm
conversations
reduction.
to, yeah.
Yeah.
And I think it's because the stigma kind of follows the language, and people lose the nuance. They lose the intent. The conversations that we should be having about reducing harms. It's the same words, but this is a philosophy. There are practices that you do to reduce harms, but the focus is just that. The focus is not on whether or not a person is using or not using substances. What we're looking at and what we're trying to impact are the bad things that can come individually, in a community, in society. Focusing on harms, I think, is what all systems really should do.
Something that I noticed very early on is that when the conversation about that comes up, and it's often like it's harm reduction or abstinence. These are the two things. And like you said, it was a noun. Now, if it was a noun and there was a box and it said harm reduction on it, and you take the harm reduction and things will be fine. It's not called, it's not, they're expecting harm reduction to eliminate the harm. And by nature, it is not about eliminating the harm. It is about reducing the harm so people can find a bit of stability in their life to maybe make some different choices, So let's take a quick break so I can read off some things. Right back. This episode is brought to you thanks to funding provided by the Canadian Society of Addiction Medicine. To learn more about them, look for their link in the show notes below. Let's get back at it. I'm interested to know how you have, or if you do, integrate harm reduction practices into your practice now. Like, do you see a value in providing or prescribing a regulated supply of a substance to someone, maybe in an interim capacity to get them to a different place, or perhaps in like a maintenance capacity? Is that something that you prescribe or would like to?
Here in Nova Scotia, we got some funding and support to set up a consult service in the main trauma hospital, the QE2 Health Sciences Center in Halifax. And we formed a team, a multidisciplinary team, and started to try to provide support on the wards. And that support that we provide within this hospital to some of the sickest people who have substance use disorders that are very severe is in the realms that you talk about, and it bridges to community treatment settings where harm reduction practices are really well developed. Any community agency that helps to manage people with substance use disorders could use a lot more resources, and we struggle to try to keep up with the demand. But in hospital, we provide pharmacological treatments that meet the need as best we can, but far beyond what existed before there was any service to guide it in the hospital.
Yeah.
We have a widespread distribution set up for reversal agents and safe use supplies. We partner with community-based organizations here in Nova Scotia that find their ways into different parts of the province to distribute, safe use equipment. In the small community where I live, or just outside of the small community where I live, we're really interested in setting up a street outreach service in a drop-in center shelter. And I'm looking forward to being able to reach some of the people who I otherwise wouldn't be able to reach. Rural areas, what we struggle with mostly is transportation. You think we have beautiful support systems set up within healthcare, but if people have to make their way to them in a rural area, they often can't. So going out into the communities, that's where we make the difference.
And we've heard, Donna and I have heard some I would describe them as horrific stories about people in remote communities having to travel ridiculous amounts of distance every day
Hmm.
to get their maintenance, to get their methadone or whatever.
Mm.
And the ministry is paying for these cab rides to go like 3 hours each way every day, and this person is just driving back and forth all day long just to get their drink. And like, it just seems to be such a broken and fractured system that with no real long-term plans in place. Now, I know, and I spoke with someone that we both know just the other day, and perhaps he mentioned it. I won't name him, but he was talking about working in a hospital and having people on these maintenance programs with probably similar
Good job. You got it. You got it.
strategies. Did I get it? Okay,
Yeah.
trying to. They're giving them the pills that they want or that they need or whatever. But okay, so now they're stable and they're in the hospital and they're getting their shot every 4 hours, or they're getting their pill every whatever. There's nowhere left for them to go after that, right? Like there's no end game other than to they're not running out the door screaming to find a fix, you know? So what can we do? Like, in your opinion, if you have someone that comes to you and like, doc, I'm sick, I need some stability like right now, and you say, okay, well, here's a shot, or here's a pill, or here's a whatever, what's the next step?
Mhm. And we're very fortunate here in Nova Scotia. There has been a lot of program development. I'd say it goes back maybe 13 or 14 years um, to set up community-based treatment settings. Um, Now there are more types than there had been, but we've labeled them opioid recovery programs, where opioid agonist treatment is given in a community setting. It's a bit different than some other parts of the country, in that community pharmacies do all of the dispensing. There's no such thing as a methadone dispensary. It's all in community pharmacies like your Lawtons and Shoppers Drug Mart and PharmaSave and Guardian, and that can be problematic too, in that they only have so much resource and so much volume, and can only do so much work and have staffing issues. And
standing in line in the morning on display type thing. Yeah,
but we have 23 of them across the province, so you're hard pressed to find a place where a person has to drive more than a half an hour to get to one of these settings. People do live quite remotely, so we can't reach every part of the province, but we're building to a place where it's accessible for everyone. We also have, I guess in Ontario, they're called RAM clinics. In BC, they're called RAC clinics, rapid access addiction medicine type hubs. We've been evolving those for 3 or 4 years, where people can get supports to try to help them stabilize their substance use and set goals and address their mental health issues and obtain safe use equipment. And it's kind of a place where you can go to try to address any of the needs that you might have that is in the community.
Clean and Sober Nation's just like spouting off policy here. Hang on. Donna, please read that for me. I'll screw it up for sure.
In the U.S., anyone can receive MAT without counseling for an opioid use disorder. While not advisable, it is within their rights as per Section 1262 of the Consolidated Appropriations Act. We provide referral lists.
I like these guys.
Yeah.
Hard Knocks Talks likes Clean and Sober Nation. Okay.
Yeah, and I guess the comment I'd make to that comment, if I could,
absolutely,
is some of my colleagues, especially those who work in rural emergency settings, don't know a lot about treatment of opioid use disorder, and by and large, they feel that the treatment that's necessary is just to start them taking methadone or buprenorphine, Suboxone, that the drug is the treatment. And that comment illustrates medication-assisted treatments, which are broader. They include medication treatments for alcohol and for other types of substance use. But in terms of opioid agonist treatment, the comment that I give my colleagues is that I don't know that the treatment is the medicine. The medicine certainly helps and gives a person an opportunity to address the problem, but it's not just medicine.
It's not addressing the
Medicine gives you an
problem.
opportunity, right?
Yeah.
Yeah, it's hard to even think about recovery if you're in the throes of withdrawal.
Yeah.
That's one of the first things I try to guide them to do, is to set up supports beyond that and not just to prescribe.
Yeah.
It's a
Well, and
key important part, but it's the beginning, right?
absolutely. And I would say, like, in our experience, because we were so stabilized on MAT, we neglected the importance of, those furthering our supports. And our doctor did recommend it a few times and suggested and
Yeah.
tried a few different avenues to, kind of guide us down there. And we just, oh no, we're good. So, if there's anybody listening, I would say, please don't just rely on Matt.
Yeah.
Get those extra supports. They are integral to
Yeah.
your ongoing success.
And sometimes, like for me early on, that was meetings. For Donna early on, that was like a few support workers that came to her home and just, talked to her off the ledge when she could call people and just like, yeah. We did find relief with the MAT program. We did find stability, but we didn't find an opportunity really to do the deeper work, and
No.
that we weren't even really aware
We weren't. No.
that there was deeper work that needed to be done.
No.
We just like, okay, well, we're not snorting pills anymore, so
Yeah.
I guess we're fixed.
And we're not sick.
Yeah.
So everything's good.
Yeah.
Well, it sounds like you reduced harms.
Well,
That's true.
we
So
certainly
I certainly
did.
wouldn't stop what you'd started. And
No.
yeah,
I'm not denouncing
idea is
MAT,
to-
and neither is Donna.
No,
We're
I'm in
not.
complete support of it.
Yeah,
I'm just
100%.
saying, just don't put all your eggs in that basket, because
There's more work to be done.
more work to be done. Yeah.
Yeah. Do you agree, David?
yeah, I think harkening back to the early days when some of these treatment programs had very rigid rules, like if you happen to show a positive drug test,
You're
well,
out.
we're going to taper you off this treatment. You're not serious about this. Get
That's what
out of
happened
here.
to
And I think
us,
all of
actually.
that was misguided, right?
Mm-hmm.
But the focus was too much on the medication for the providers too, right? And yeah, I think the value, as we talked about earlier, is more in the relationship than it is in the prescription or the medication. That when the time comes that there are other things that you want to do in terms of addressing mental health issues or substance use, you have that attachment, you have that trust relationship that you've developed with the program.
And it's always
And
seemed
I've had
so.
people that it's taken years.
Yeah, and it seems so contrary to me now looking back, and it took me a number of years into my recovery to really to see it through this lens, but to basically stop treating someone for a disorder because they're displaying symptoms of that disorder, it doesn't really make sense to me, and I think that we're in agreement on that. Is that accurate, Dave?
Yeah, and you mentioned about words matter and language. And one of the things that I think of when talking about this specifically is the notion that there are providers and people in society that look at opioid agonist treatment itself as just being replacing one addiction with another, just misunderstanding what addiction is all about. Seeing the medication itself as an addiction, maybe a dependence, but that's different than addiction.
Like and even to this day, I have friends, and like I have friends that think differently than me, and that's fine, right? Like if we only worked with people that we agreed 100% with, then we wouldn't have anyone to work with. So, but they go onto social media and they've got a decent following, and they're talking about how methadone is a crutch, right? And how it is a stepping stone, and how it is all of these, these things. And I kind of can't disagree with them, now, is it, and the question comes up, and I know you don't like the word, but this is the question that comes up, is like, are you clean? if you're on methadone? Are you clean if you're on Suboxone? Are you clean if you are smoking marijuana? And to me, it's like, I'm more concerned, like, are you happy? Like, why isn't that a concern or a point of conversation? Are you well? Is your life meaningful? So how do you come to a place where you can say, okay, I've had success with this patient. Go on now into the world and live your life of meaning and fulfillment. Is there like sort of like a benchmark thing that you look for to sort of check that box?
Yeah, there are a couple of conversations in there, Danny. I guess the first one is the notion that people are fixed or cured. That this tendency that they might have to have addictive behavior is probably part of their makeup, part
Mm-hmm.
of who they are, and maybe that circuitry in their brain has that tendency throughout a lifespan. So there may be times again that they struggle. We don't look at people who have asthma or diabetes as being cured of it once their treatment is effective and they have no trouble breathing anymore, or their blood sugar is okay. So let's say go on your merry way. So that's one of the conversations, to have a mindset that we may have stabilized this, but it's not gone,
Mm-hmm.
that you may struggle again. And we want to maintain this relationship over a longer period of time.
Mm-hmm.
Look at it as being something that may cause difficulty from time to time. The other part of it, I think, is, and I've taken an interest in this recently, is to try to have some clear ways of measuring success. The one
Mm-hmm.
that's intrigued me the most has been, we've picked up a tool that we're probably going to use to measure what impact we're having in the healthcare treatment settings, and it's called the BARC-10, 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 developed by a team in the United States, and it lists many of the things that you alluded to. Are you satisfied with your life? Do you have a safe place to live? The
Mm-hmm.
very specific things that are meaningful when it comes to uh, stabilizing or improving from an addictive disorder. Um, but those things are so individual. I rely on a person to tell me, you know, we've had this relationship for some time. Uh, we've worked at it. How do you think you're doing? Like, where's your life now compared to what it was when I first met you 3 or 4 years ago? And what
Mm-hmm.
work is left to do? And it's a moving target, right? You may still
Mm-hmm.
have goals even after things have really stabilized, and your goals change over time.
And man, I can speak to that. Like I just took. I mean, I've been at this for a while. It's been a long time since I've had um, an unhealthy relationship with substances, and to this day, I will reach a certain understanding in my own mental health, or in my relationships, or in my considerations, and then a whole new thing will be opened up to me, and now I've got all of this much more work to do, and off we go again. Like, I think that, but I do think that there comes a time, and there has been in my life, where recovery from my substance use has ended, and now I'm just learning to live within the human condition and facing challenges not unlike anyone else. But I'm curious if you could share with us sometimes that you have seen success with people who continued to use substances, but not necessarily in what you would consider a problematic way, and went on to live that life of meaning that we're talking about.
I have one person who I've helped to manage their care now for 7 or 8 years, who is just in the final stages of completing university, and excelling at the top of their class, and has a very bright future, and has a child, and like all of these things that have come through the process of stabilization and treatment. And it's very, very rewarding to see it one step at a time. And I'm sure that, yeah, you've had friends and family members in your own index cases that drive you to just to see that there's hope, right?
Mm-hmm.
We tell
Mm-hmm.
these stories to give others hope.
Yeah.
And I appreciate that you make space for this to happen. It's a very important part of the field.
Mm-hmm.
I really liked, if I can backtrack a little bit, the comment that you made. Um, when we were talking about dependency versus addiction. And that really piqued my interest because my father had been basically coerced off of, he was prescribed an opioid for pain. He's had 2 hip replacements, open heart surgeries, like he's, you know, so he had been on low grade opioid for quite some time, and his doctor guilted him essentially out of he switched he wanted him to get off of the opioids because he was addicted. Why I'm focusing on this is that importance in language. My dad felt terrible, and after having witnessed what Dan and I went through, he he agreed. He's like, "Oh my God, like, oh, I got to get off this stuff." So then he stopped and he went on, I think, Tylenol or Advil or something, and he's been in excruciating pain.
Yeah, his quality of
His
life was
quality of
very much
life
diminished.
has diminished significantly, and then now he went back to the doctor saying, like, I think I, maybe made a mistake in that decision, and he can't get back on them.
Mm-hmm.
And
Yeah,
it's tragic to me.
kind of sad that the pendulum keeps swinging. Now we're in a place where older people are fearful of some of these types of prescribed medications just because of the potential they have to be used non-medically.
Mhm.
I've had more than one little old lady refuse prescriptions for like even a broken arm for exactly the same reason. I
Mhm.
don't want to get addicted. Those are some of the hidden harms, societal harms to these kinds of narratives.
But even
Yeah,
from the
that's
physician's
really kind of sad.
perspective, he didn't seem to
Mm.
understand the difference between an addiction and a dependency, and then the impact on quality of life. That's
Yeah,
terrifying to me.
that's very basic.
Mm-hmm.
Yeah, this person, if you were to kind of present them with the DSM criteria, the DSM is the book that is used by healthcare professionals to try to help identify and diagnose these disorders. If you were to go
Mm-hmm.
through the list with a physician and say, well, an addiction includes this, and this. How many of these criteria does this person in front of you have?
Mm-hmm.
And he would have none, right?
Mhm.
Or maybe one. A dependence just means that your body has gotten used to a drug and will miss it when it's gone. That's it.
Mm-hmm.
The behaviors around addiction are things like craving and compulsive use and serious consequences of that use. It's the
Mm-hmm.
behaviors that make the disease.
Yeah. Of which there.
But yeah,
Whoa!
that physician didn't know
Did you
any of the
just call it a?
basics. Hmm?
I'm sorry to interrupt you. Did you just call it a disease?
Yeah, there's a lot of debate in there too,
I'm
and a
not
lot
going
of
to.
that is historical. Yeah.
Yeah, and I'm not here to say what's right and what's wrong, but I thought the disease model is kind of like going by the wayside, so to speak.
It is. It is. In fact, I check my own language when I'm talking about, and this comes up usually when we're talking about co-occurring disorders, people
Mm.
with both a substance use issue and a mental health disorder.
Mm-hmm.
Uh, Label addictive disorders as chronic medical problems. And the difficulty comes when you try to frame it in that model. The model comes from primary care, where it's called a chronic disease model. So the word disease is in it. You'll
Mm.
see people trip up on it from time to time.
Mm-hmm.
But yeah, the important point is that this is a long lasting issue. It doesn't have a cure,
Yeah.
not whether or not it's disease. We focus on the length of time a person needs help and needs care and support.
Yeah. Yeah. Correct me if I'm wrong, and perhaps you're not seeing it in your neck of the woods, but there seems to be in central Canada and in BC now a recent push for recovery-oriented systems of care. There seems to be we all want to move away from harm reduction now. We tried it didn't work. We tried it for 5 minutes and it didn't work right away, so we're gonna jump ship and go. Like, are you concerned? Are you concerned that it seems as though harm reduction strategies are being defunded across our country?
I am concerned, yes, because I think what we require and what you'll hear the minister, the federal minister of mental health and addictions, talk about is the requirement to have a spectrum of care that
Mm-hmm.
includes harm reduction, that includes recovery-oriented systems. And we
Yes.
take away any one of these elements, like because of ideology or policy or any kind of other uh, motivations, we are really taking away from how effective that we can be as a society in addressing these issues.
Mm-hmm.
So, as elements of it are taken away through funding mechanisms, we lose. We certainly
Yeah.
lose, and I think we need to be expanding what we offer to people rather than contracting it.
Mm-hmm. Yeah.
We're fortunate here in Nova Scotia. We have a provincial government who's very supportive and investing in these systems. We have many to build yet. Like, we still don't have an injectable opioid agonist treatment as an option for treatment. We lack significant evidence-based residential treatment options for people when they're required. So we have lots of stuff to be built, but my focus here is to try to have as much on that spectrum as we possibly can, to
Yeah.
the exclusion of nothing. We
Yeah.
really need to be, people are dying. We need to
Mhm.
put everything
And
out there that we can to try to save lives.
and I agree. I like I was talking about earlier, our language in mainstream seems to be very divisive. Divisive?
Mhm.
Am I saying? I
Yeah.
always look at, like,
Yep.
am I saying the word right, Donna, babe? But if it's like, it's got to be this or that. It's like, oh, we're gonna do harm reduction, like you said with the noun. We're gonna do the harm reduction, or we're gonna do the abstinence, and it needs to be this and that, because, like, even sitting in this room with my wife, I mean, the 12 steps, the program, it got me to a place where I needed to be. It was very useful in my life. Did it get me all the way there? No, because I'm still growing. I'm still doing all these things, but it's, for a time, it was very useful for me. And for Donna, she never set foot in the rooms, right? She went a whole different direction. So the idea of pigeonholing into people of this one modality of care, I think it will bring more harm than good in the end. Now, I know that you wanted to touch on language, and I want to do that before we turn you loose here. And Donna sort of brought it to the forefront with the difference between dependence and addiction. What are some other places of concern that you're seeing where language is bringing harm to people?
There are different types of stigma. The one that I encounter a lot, and we touched on it when we first started to talking, is when people refer to themselves as an addict. Yeah, I find it a little grating, and I'll often kind of stop in the moment with people and have a conversation just about what they just called themselves, and I understand why it is. It depends on the setting, but to me, that's a form of othering, and people kind of identifying themselves as another, and I struggle with it. There is a a publication out there that helped guide me. That it was an unusual source. It was a publication for journalists called Mindset, to help guide them on how to write, sensibly about mental health issues using the right language. And they promote something called person first language. So first and foremost, you're not an addict. You're a person with a substance use issue or a substance use disorder, or experiencing harms from substance use. So that's one example. But yeah, we hear different words every day, and I think less important than the individual words and having an approach to them is having conversations about the words that we use.
Mm-hmm. Beautiful. I think we nailed it, man. Is there anything that you'd like to touch on that we didn't hit?
No, I thank you so much for doing this, Danny. This is important work, and I'll come back anytime if you'd like to have more conversations. And I look forward to your presence at our conferences again if you'd like to come back and
We would love that.
spend time
In
with
fact,
us.
I just reached out to your board the other day.
Fantastic. Yeah, we'll be in Hamilton this coming year. Again, this has been a joy. We finally got around to doing it, so I appreciate you and Donna setting this up and inviting me. Thank you very
Awesome.
much.
Yes, you're very welcome. Thank you, Dave, for joining us tonight. Thank you for sharing your experiences and your knowledge with us, and we'll let you go. Thanks so much.
Thanks, Dave. Take care.
Okay. Thank you.
Okay, if you got anything out of this show tonight and you are not yet subscribed to us on YouTube, please click that subscribe button. Give us a like, turn on notifications. We're going live all the time. If you don't have time to sit and watch us for an hour, you can find us on Apple Podcasts, Google Podcasts, Spotify, wherever you listen to podcasts. We're super easy to find. Give us a Google. That's all I got for you tonight. Thanks so much. Take care, everyone.
Say, this is Hard Knocks Talks.